Go. You good? Okay. So, I'm Nick, and I'm going to do a homework assignment. Obviously, this is Devin Turner's Airway class. Today, we're going to do a thorough medical assessment on the victim as seen here. We're going to call him Jane, and it is still a guy. Jane is an 89-year-old male with severe chest pain, difficulty breathing. Okay, that's the chief complaint. His history is CHF and diabetes. He has had one myocardial infarction 3 years ago. What he was doing before the complaint started was he was cutting wood. He likes to push himself. So right now he's sitting on his front lawn, and I arrive on scene. The scene is not safe because we're in the middle of a crisis. So I have to put my proper PPE on before the scene is deemed safe. Okay, now the scene is safe. I have my BSI on. It's a sit call, chief complaint, difficulty breathing, and chest pain. I have one patient. I'm not going to have any additional help because I'm going to put myself in a remote setting where I am one of the few paramedics in service. This is an ALS ambulance. We're 25 minutes from the nearest hospital. This hospital does have a cath lab. I'm not going to consider stabilization of the C-spine because there's no fall involved. All right, starting off with my primary assessment, airway, breathing, and circulation. Before I put the mask on the patient, I saw that the patient had a clear and patent airway. He was open and talking to me. Once I have that confirmed, I'm going to move on to my breathing assessment. The patient is breathing. The patient's breathing very rapidly. Let's pretend the patient's holding his own chest and breathing very vigorously. I put an SpO2 meter on him. He reads at 85%. He is alert and oriented ×4. He's alert to person, place, time, and event. And the most important life threat right now is going to be the chief complaint. Both the difficulty breathing and the chest pain is what I'm going to be most worried about, or most focused on. Circulation assessment is going to confirm I have radial pulses, so I know he's pumping blood pretty decently. And I'm going to move on to my history taking. Okay, so I'm going to start off with my OPQRST onset. The patient was cutting wood. During that effort, he felt a sudden onset of chest pain. It was acute. It came on without forewarning. He said that he does have a similar experience to talk about 3 years ago. The patient is actually rating his pain on a 9 or an 8 out of 10 currently. Provocation of this injury is going to be when he breathes. He feels that the more he breathes, the more panicked he gets, the more the pain increases within his chest. He says that it feels like it is going to radiate from the front to the back, so it's almost like a penetrating pain from the front of his chest to the back of his scapula, and he says that it wings off to the left side of his scapula. Obviously, like I said, the radiation region is going to be chest, back, and left shoulder. And it has lasted for 30 minutes total. All right, sample. My sample history is going to say, the patient's going to say that sorry, I lost my place. No allergies or medications, and he's not currently on any medications. He doesn't take his medications, and he stopped going to the doctor. So even though he has a history of chest pain, CHF, CHF, and diabetes, he doesn't treat it. So he's on his own. I'm going to move on to my secondary assessment, starting off with lung sounds. I'm going to make sure, just as we were taught before, never listen directly on the scapula. I'm always going to listen in the spaces right outside the spine and then in the lower rib cage for the back. I'm going to have the patient take a deep breath for each one. I hear some very heavy fluid in his lungs as he breathes. The patient is stating that he has been diagnosed in the previous 5 years with pulmonary edema because of his CHF. So not only do we have a patient who is experiencing what I'm suspecting is a acute MI, an acute inferior MI, but I'm also going to consider the treatment because the patient has a very severe cardiac history. Obviously he has CHF, and the potential to have an MI while having CHF. For my differential, I'm going to assume that it is moving a lot of blood and fluid to the alveoli of the lungs. The alveoli are filling up, and I want to consider treatment for the pulmonary edema while I take treatment precautions for the acute MI. Moving on with my secondary assessment and diagnosis. I'm going to take a blood pressure. Obviously, for the second time, I'm not going to actually put it on him, but I'm taking a blood pressure. His vitals are going to be 150 over 100 for his blood pressure. His pulse rate is 160 and thready, so tachycardic and thready. Respirations 25, and his respiration quality is shallow and rapid. I'm gonna put the patient on a nasal end-tidal CO2 monitor. On that end-tidal CO2 monitor, I see that his end-tidal CO2 reached 30. He obviously his CHF and pulmonary edema are gonna come into play for this differential. I'm also gonna put a 12 lead on the patient. The 12 lead identifies a STEMI. So my suspicion is confirmed, and right now before I go into my treatments, I'm gonna go over what I've just discovered. So, like I said, we have pulmonary edema, we have CHF, both of which have been diagnosed, no history of COPD. His blood pressure is appropriate for CPAP, 150 over 100, and he has a confirmed STEMI on his 12 lead. Since I didn't say before, right after my initial assessment, I am going to deem him a treat and go, so I'm going to treat him as quickly as I can in the field and then get en route to the hospital. And then as soon as I get my last treatment done, we're going to start hitting the road and get going. Lights and sirens, code red patient, all that stuff. And I'll read my PCR after I get to my treatments. Okay, so my first treatment here is I want to manage his airway as best as I can. The way I'm going to do this is I'm going to give him a CPAP. I know that with CPAP we do risk vasoconstriction, and because of that vasoconstriction, we might have a hard time dilating the blood vessels and allowing for free movement of the blood, and it might. Some might say that it could interfere with my actual treatment for the MI itself. But because we were always taught to do ABCs first and to always treat pulmonary edema decently or fairly aggressively, I'm going to choose to CPAP the patient with a setting of 8, considering that we have about a 20-minute transport to the hospital. The CPAP is going to keep on going. I'm not going to put him on a nebulizer. No nebulizer. He's going to stay on the CPAP for the remainder of the trip. The doctors can take it off if they want when we get there. My next treatment, like I said, his vitals are going to allow for CPAP. I'm going to monitor his vitals while he's on the CPAP, make sure his blood pressure stays above 110. The next thing I'm going to do is ASA, aspirin. I'm going to give him 3 81 milligram tablets. So that's 320 mgs altogether of aspirin. I'm going to have him chew them and swallow them. Obviously, we're going to monitor the patient, monitor his vitals after that treatment is performed, but I definitely don't want to stop there. Because we have a working knowledge as far as cardiac emergencies go, We have a working knowledge of nitroglycerin and how we can give sublingual nitro to a cardiac patient. I want to take it a step further, and I actually want to give him a nitro drip diluted in a 1 liter bag of normal saline. I'm going to titrate the dosage itself to 10 micrograms per minute, and as long as the systolic remains above 100, so the systolic blood pressure has to remain over 100 for me to continue both of these treatments, because I know the nitro drip and the CPAP both can have an impact on his blood pressure. So I'm going to make sure that blood pressure stays appropriately high for me to keep on administering these treatments. If the blood pressure drops, then I'm going to obviously discontinue these treatments. For the sake of this scenario, the patient is going to react well to these treatments, and we're going to keep them going for the entire transport. Obviously, the 12 lead, I'm going to consider that a treatment itself, and we have a diagnosed STEMI with the 12 lead. Go ahead and pause it.